This is a 24/7nursetutors.com lecture. 24/7 Nurse Tutors, providing unlimited tutoring.
Welcome, and thank you for joining us. Maternal Newborn, Part 2.
RH incompatibility and sensitization is very important, so we're going to spend some time discussing this. It is important a history is obtained at the first prenatal visit. Antibody screens, indirect Combs test, determines sensitization to Rh antigen. Women who become pregnant with an Rh positive embryo or fetus from an Rh positive father may become sensitized to the Rh antigen if there is any accidental contact between maternal and fetal blood. Other causes of Rh sensitization might be a blood transfusion of Rh positive blood to an Rh negative woman, or fetal-maternal blood contact during an amniocentesis or other invasive procedure. Sensitized Rh negative women develop anti-Rh antibodies, which may cross the placenta in subsequent Rh positive pregnancies and attack and destroy the fetal red blood cells. Fetal effects of Rh incompatibility and sensitization are progressively severe. Hemolysis of fetal erythrocytes leads to a greatly increased immature red blood cell production, termed erythroblastosis fetalis. Continued red blood cell destruction and anemia results in jaundice and marked fetal edema, known as hydrops fetalis, and may lead to congestive heart failure. Breakdown of the red blood cells releases bilirubin, causing jaundice. High levels of circulating bilirubin can cause kernicterus, a condition of yellow staining of the basal ganglia and brain from bilirubin deposits, and may result in permanent neurological damage. An indirect Combs test on maternal blood is used to determine whether the Rh negative client has developed antibodies to the Rh antigen. Serial antibody screening should continue throughout pregnancy to identify increasing antibody production. A direct Combs test is done on the infant's blood after birth to identify maternal antibodies attached to the fetal red blood cells. As a nurse, you provide support and education to the client and family. The client should carry an Rh negative identification card and recognize that she may need the medication RhoGAM with future pregnancies. Unsensitized Rh negative clients should be given 300 micrograms of Rh immune globulin IM at 28 weeks and also within 72 hours of delivery. The antibodies in the immune globulin bind with any Rh antigens in maternal circulation. This provides massive immunity to the mother, so she will not become sensitized to any Rh antigens and produce antibodies of her own. A sinusoidal electronic fetal monitoring pattern indicates severe fetal anemia. A BPP may be used to identify a compromised fetus. An early delivery with phototherapy and exchange transfusions may be planned if the fetus is developing anemia close to term. An intrauterine exchange transfusion may be performed for the severely affected fetus until viability is reached. Let's look at a pregnancy with an Rh positive fetus. Some Rh positive blood enters the mother's blood. As the placenta separates, the mother is further exposed to the Rh positive blood. In subsequent pregnancies with an Rh positive fetus, Rh positive red blood cells are attacked by the anti-Rh positive maternal antibodies, causing hemolysis of the red blood cells in the fetus. Let's discuss the drug that can make a difference, RhoGAM. RhoGAM is given to Rh negative women with possible exposure to Rh positive blood. When is RhoGAM given? As we discussed earlier, it's given IM within 72 hours after delivery, at 28 weeks, after a miscarriage, and invasive procedures. 2 RNs need to check the ROGAM. Why do 2 RNs need to check? Right, because it is a blood product. Let's talk about rubella. Remember, women susceptible to rubella and varicella should be vaccinated immediately after delivery. This vaccine is given subcutaneously to non-immune clients before discharge from the hospital. Can the client breastfeed? Yes. Do we have an immunocompromised client? No. After vaccine, how many months must the client avoid pregnancy? 3 months. Rubella is usually a mild, self-limiting viral infection. Its major complication of maternal infection in early pregnancy is congenital rubella syndrome, or CRS.
How do nurses calculate the expected due date of a pregnant mom? We use the Nagel's rule. From the first day of the patient's menstrual cycle, we add 7 days and minus 3 months. And depending on the time of the year, we might add 1 year. For example, if a patient gets pregnant in August, she will have her baby the following year. Let's discuss decelerations and accelerations. Have you heard of veal chop? Well, this is an easy way women's health nurses use to remember decels. V stands for variable decels, means that the cord is being compressed. The intervention? Move mom left lateral. E is for early decels, and this means the baby's head is being compressed. What's your intervention? Identify labor progress. A is for accelerations, and they're okay. Intervention? Do nothing. L means a late decel, and that means the placenta is insufficient. This is an emergency. Intervention? Evaluate, give oxygen, put mom in the lateral position, discontinue oxytocin if infusing, and prepare for the delivery of the baby. Let's discuss labor progression. Cervical dilation is from 0 to 10 centimeters. When mom is in labor for the baby to be delivered, she must be 10 centimeters dilated and 100% effaced. Let's discuss station. Station 0 means the baby is engaged. Anytime we have a rupture of the membranes, or ROM, with negative station, we are worried about a prolapsed cord. Positive means baby is coming out. We always want positive. Let's discuss position. This is the relationship of the point of reference, the occiput sacrum, acromion, on the fetal presenting part of the mother's pelvis. The left occiput anterior is the most common. The relationship of the long axis, or the spine of the fetus, to the long axis spine of the mother is known as the lie.
Remember, you are more than a conqueror, and you will be successful. Join me as we review core content in the next unit.